Medical mistakes are the third leading cause of death in the United States, but we know how to stop that.
Physicians are trained to think that they need to be right all the time.
All right, sir, just take it easy.
Everyone is trained very much in a silo. We've never worked together.
Temperature.
What we're trying to do is completely build a new system from one that really never was a system.
I think it's very difficult for a physician in general to admit that they made a mistake. It's very difficult to say I was wrong. But when a physician says now I am wrong or I was wrong and we learn from it, I think it makes for a much better experience.
They're trained to think that they need to be right, and they need to be right all the time, and they need to have all the answers. And sometimes even when they have an answer, that nothing else will even be entertained. Not all physicians are like that, but there are many that have been trained that way, and it is part of a culture that's difficult to overcome.
CRM, which we called Crew Resource Management in aviation, when applied to medicine, has to be applied in a very, very specific way that is really medical only. In other words, we have to translate a lot of things, but the beauty of it is the principles are identical. Now, one of the things that has been done here with Baptist and Auburn in conjunction is a pioneering element in going beyond just using simulation as technical training, training of how to do a particular procedure or even practicing the procedure itself. What they're doing is practicing what is absolutely vital to win this patient safety battle that we're in and get to zero, and that is training people how to deal with each other on a level playing field.
When CRM came out in aviation, it was basically about captain's leadership, and it came about because there was an autocratic captain that did not listen to the inputs of the crew particularly well, and as a consequence they made some bad decisions. And so a few years ago, probably about a decade or so ago, there was a move within healthcare to say we have a fairly similar setup. There's a hierarchical organization, a lot of highly trained people that have to make a good decision in a short amount of time. And so it's evolved from just a fixing something that's broken to a how do we perform more effectively as a team? How do we do something that is a higher level of care for the patient? And it's ultimately about the patient.
SMART is basically the melding of the principles of CRM for open and barrierless communication and using all available resources, and that's everybody, into a medical setting.
What it was like before was mass chaos. It was loud, it was unorganized, people running everywhere. It just was very chaotic.
I will be talking, EMS will be talking, the nurses will be talking, bystanders will come in and out of the room, and I would have to repeat myself 4, 5, 6 times, ask for medications 3 or 4 times.
It's very controlled and very organized now. We have team huddles before a patient rolls in that might be very emergent or very ill. We have debriefings after. We have worked with our pre-hospital folks to understand the principles. So when they bring a patient in now, they ask, who is the team leader? They come in the room, they give a report, and they leave.
Twice already, I've been almost to the point of pushing the wrong amount of drug or milligrams of a drug into a patient just because I ordered it, I received it, but when I did the readback and the nurse did the readback back to me, we confirmed the dose was the wrong dose.
We've had several patients where the technique of using the team leader who is not involved in patient care has actually picked up on issues with a patient. For instance, we had a trauma patient come in. Everybody was focused on the trauma aspect of the patient. The team leader happened to look at the monitor and noticed that not only was the patient a trauma victim, but they were having an active MI at the same time. And we were able to intervene very quickly, and that patient left the hospital.
I recommend pan scan, x-rays, lab, prepare for intubation and chest tube.
Is this a 911 trauma alert?
It is a 911 trauma alert.
Sir? Sir, can you hear me? Sir?
Simulation is the answer, not just in technical simulation, but simulation in terms of how we relate to each other and how we communicate.
Strider noted.
Airway is compromised. Can we get ready to intubate, please?
We can prepare for intubation.
Can we have etomidate, 20 milligrams IV?
And when you open your eyes and your ears, you will be a better physician. You will practice safer medicine, and you'll give your patients the thing you're trying to give them, which is the best possible care you could deliver.
I have 20 milligrams of etomidate. Do you concur, Dr. Rios?
Etomidate, 20 milligrams IV, being pushed as we speak.
And I know it's the right thing to do for patients. Ultimately, I think we save lives.
20 milligrams of etomidate in by Dr. Rios. Catherine, if you would help Dr. Rios out with that inline mobilization. 16 French Foley in place.
Simulation is the core. Adults learn by doing, by hands-on. While we may be able to get information via book learning or lectures, when it comes to actual practice, we have to do hands-on.
Simulators are actually very effective. There's different components to simulation. There's the technical piece where you can practice an intubation or a central line. Some of the mannequins right now are very good, but simulation is also about simulating communication and feedback and practicing scenarios over and over. That's sort of the way the brain works. So you and your mind have to become used to developing these scenarios of pure communication, where every order that I give is read back to me accurately and I confirm it, so I know there will not be an error. So that's also simulation. So we simulate technical piece, but we also simulate the communication, engagement, and assessment piece.
What's it going to be like if I have to start the IV on the 2-pound baby, and maybe I practice the skill over and over again through simulation in my training, but now I've got a mother at the bedside who's crying. There could be an infant that may be coding in the room next to me, and it's taken a lot of staff over there. And there's an emotional connection that you have as a nurse to what's going on around you. All of those are factors that you can overlay on top of the clinical simulation to make sure that it's a real-life example.
That's what Auburn and Baptist are engaged in simulation. They're putting people in rooms that not for the purpose of training the technical side of it, but for the purpose of training relationally.
And again, you learn so much more effectively. We film it, we debrief it, we let folks look at it and say, okay, I get what I was doing or what I wasn't doing, and we get do-overs. Well, in real life, you don't get do-overs.
So often in healthcare, we don't want to listen to everybody. We want to put people in certain categories and not necessarily think they have a whole lot to offer. And smart training emphasizes that everybody sees something from a different point of view. And if you're not listening to all of those points of view, you may miss something.
It really becomes a collaborative effort and a better working relationship because there's not the egos involved and those kinds of things. It's all about what that patient needs.
I think simulation is the next level in the evolution of healthcare. I think we've gone to evidence-based practice. I think that's a tremendous step forward. We've improved the processes and procedures, but because of just the sheer volume of what's being done in healthcare, there isn't the opportunity to practice very often. Practice improves performance.
The reality of what we're facing in patient safety is really quite startling in terms of where we were, where we are today, and where we have to go. Hospitals have been built for the doctors, and yet we've got to rebuild them, in effect, for the patients. The moral, the ethical, the logical, and certainly the economic rationale for this is beyond question. We have to do this yesterday, and the central aspect of this is training people for relationships, training people to communicate.
And when I see folks like Dr. Rios or Anitra Jones or Paula Brennan or so many faces that you haven't met that believe that their attitude toward providing care and the way that they practice has changed so dramatically because of smart training, and because of that they are taking better care of patients, that to me is all the ROI that I need. That's exactly the kind of change that we need in healthcare.